Happy Saturday. And today we have a global VMR with Alfaisal University with us. We have Mohammed, Omar, Anas, Man, Bar, Mohammed joined us from Riyadh. So happy to have them here on this Saturday morning. And we're excited to have a fascinating case presented by the Man. So I will pass on the mic to another team member, Maria.
Thank you. Hi, everyone. That was an amazing introduction. I have nothing to add to it. I just want to say thank you to everybody who's here. I know it's a very nerve-wracking weekend, but we're going to put that energy into having fun and being with one another, learning a little bit about our friends. We wanted to do this program. We've invited Hernan from Chile, who is here. Also, we've invited folks from Zambia and Portugal, but when we started inviting programs, I wanted to reach out to Mohammed, or we've become friends through VMR and our love for neurology and our love for words and languages and culture. And so I knew he would bring some friends and have fun together. So Moha, welcome. Thank you for accepting the invitation. Do you want to introduce yourself and your friends?
Of course. Thank you for inviting us. We're all happy to be here. So my name is Mohammed Lashwal. I think I first joined CP Solvers and attended back during the height of the pandemic, I think maybe April, May 2020. So that's 2 years ago. It's crazy. Time flies. And today we have the honor of Man is going to be presenting a case for us that he has seen. Man is an internal medicine resident here in Saudi Arabia, and I am proud to call him one of my classmates. And he's also applying to internal medicine residency in the US this year. Anas and Omar are also applying to internal medicine residency this year in the US. And we have Mohammed Salik and Bara Al-Arifi. And they're also two of my classmates and really good friends of mine. So we're all excited to be here. And we're all excited to get started.
Thank you, Man. Do you want to say hi and introduce yourself as well?
Of course. Thank you very much for giving me this opportunity. So again, my name is Ma'an Awad. I am a fresh graduate of Alfaisal University, and I just started the internal medicine residency at one of the hospitals here in Riyadh, in Saudi Arabia, around 5 months ago. And I am truly honored, and I appreciate the opportunity to present a case in your virtual morning report. And I hope that the learning points would be beneficial. Just a quick background about the hospital where I'm practicing. So it's one of the oldest hospitals in Riyadh, and it's called the King Saud Medical City. However, it's known in the public as Al Shimaisi, after the neighborhood in which the hospital is located. And what's interesting about this hospital is that it doesn't have a strict eligibility requirement in terms of who gets treatment. And so you get a chance to see a unique patient population that sometimes you have to take in mind their financial and economic background in terms of, the medications and treatment that you are prescribing. So I hope that today's case would be beneficial and enjoyable. Thank you. So shall we start?
Thank you so much. I can't wait. Yeah, we'll start in a minute. After the case, we'll sort of do a Q&A, and I can't wait to listen to more about your experience. Ravi will be facilitating. Ravi, do you want to say hi before we start?
Hello, hello, hello. Welcome, everybody. It's not even 9:10 yet, which is usually or 7 past the hour, and we already have almost 30 people here. So I anticipate a larger and larger audience to celebrate our friends from Saudi Arabia. I think it's a delight to be here and a delight to welcome you all for many reasons. One of which is this is both a global VMR in a region that we haven't made contact with yet in VMR, but also a personal touch with Maria and Mohammed going a long, long way back. And for me, I'm thrilled to hear your case today, and then learn more as we go through your case about what is unique about this case coming from Saudi Arabia. It's a delight, especially because we had another case from Saudi Arabia presented yesterday, coincidentally, with our dear friend from Muhammad, who also presented spontaneously, who was also here. But Man, I'll give you the mic and not delay us further, but I will remind people this on Saturday, it's a collective exercise. So I will ask each of you to participate and get all the voices from across the world. So please, please, please share your thoughts in the chat. If the chat is silent, I promise I will draw you in with one tactic or the other, so you can't hide for long. All right, Man, I'll give you the mic and we'll jump right in.
All right, thank you very much. So let's start. Okay, so starting with the chief complaint and the history of presenting illness. Our patient is a 76-year-old gentleman who has no past medical history. He presented to the emergency department with a 2-day history of palpitations and generalized fatigue. On history of presenting illness, the patient was in his usual state of health until one day when he woke up in the morning and he started to feel those palpitations, which he described as a fast beating sound in his right ear. In addition to that, he was feeling fatigued, unable to perform his daily activities, such as going to the grocery store. Apart from that, the patient did not have any fever, night sweats, weight loss over the past few months. He did not have shortness of breath, no chest pain. He did not have any recent illness. He also did not have nausea or vomiting, no history of orthopnea or paroxysmal nocturnal dyspnea. He did not have any change in mood or hyperactivity. He describes the palpitation as being fast beating sound in his right ear that is continuous. It stops for 1 to 2 minutes and then he starts to notice it again. And it was very uncomfortable for him. That was the main reason why he came to the hospital. It was not associated with exertion, and he did not notice any clear provoking or relieving factors. So that's with regards to the history of presenting illness.
Man, I'm getting palpitations just listening to this incredible presentation. One, I just wanted to acknowledge that presenting in a different language is very hard. And not only are you putting the stories together so cohesively in English, but also the way you're delivering it with pauses and stopping and slowing down is a marker of a great case presenter. While I ask the chat to get your thoughts about this case, Man, can you tell us how often in Saudi Arabia are you using any other languages apart from Arabic when you talk in medicine? Is it some parts of the world they actually use English or French or other languages? What is it like learning in Saudi Arabia?
Well, when it comes to medicine, the
Yes.
practice of medicine is basically in English in Saudi Arabia.
I see.
So you have to, get to learn about English through school or while you are in medicine, basically.
Yeah, it's the same in Lebanon. Very, very interesting. It's funny how some parts of the world do that. I don't even know how to say spleen or liver in Arabic. I have no idea. I don't know if you do. You do?
Well, I do, but,
well, Mohammed definitely knows. That's for sure.
Yeah, me too, but not with the complex, medical terminology. That I could not translate.
Exactly. All right. Well, thank you for that. Tabish has some great thoughts. Tabish, do you want to unmute and share your thoughts?
Yes, hello everyone. I am Tabish from India.
Hi, Tavish. Nice to meet you. Where in India are you calling from?
I am from Jharkhand.
Jharkhand. Okay, and where is that? Is it what part of India?
East India, near Bengal.
Near Bengal. Welcome, welcome. So yeah, tell us more about what you were thinking.
Yeah, I think palpitations could be divided into headings. Like it could be due to cardiac causes, due to psychiatric. It could be due to sinus tachycardia or with a normal sinus rhythm. In cardiac, we could be having arrhythmias with AFib, flutter, or sick sinus, or other causes of SVT. And we could be also having ventricular tachycardia. And psychiatric causes, a few comes to mind, like panic disorder or agoraphobia, or anxiety disorder could be there. And sinus tachycardia, there are a few like hypothyroidism, hypoglycemia, fever, and even anemia or hypovolemia or sepsis could be there. Or some medications could also be causing that. And finally, what comes to mind is a normal sinus rhythm with unclear cause of palpitations. That's all.
That's absolutely superb. I feel like you can write a New England Journal review article on palpitations. That was absolutely superb. Thank you. Jorge has some really important questions to understand the palpitations a little bit better. Jorge, do you want to share them? And maybe show us another picture of your dog?
They're here.
Hello.
Not impressed. So no, I was just thinking like I would like to know first if there's any like red flags, like chest pain, loss of consciousness, or like lightheaded. If there's none of that, then we can go. Also, I would like the patient to describe me what really he's feeling with palpitations. Also, if he tells you it's like for 20 minutes, you want to know like if it's like constant for 20 minutes or you like intermittent for like 20 minutes, because then it's different category and stuff like that. Yeah.
100%. That's absolutely superb. Jorge, can you remind me, where are you calling from?
Sorry. I'm in Louisville. I'm from Puerto Rico, but I work at the VA here at the hospitalist, the VA here in Louisville.
Yeah. That's so cool. I'm also a fellow VA person. I work in the same.
Oh, really?
Yeah.
Were you in the Army?
I was not. I'm not a veteran. No.
Okay. Yeah. I just got out last year. There. Yeah.
Nice. Awesome. Well, thank you for joining us.
Thank you. Yeah.
There's more and more thoughts trickling in the chat, but I would like to poke a friend of mine who has their video on, even though she hasn't said anything in the chat yet. Jane, can I bug you real quick?
Yeah, sure.
Okay, can I tell you, full disclosure, can I tell you why I'm bugging you?
Why?
I'm bugging you because I really fundamentally believe that every single time you've said anything ever, it's been absolutely superb. So I feel very comfortable spontaneously picking on you because you've like hit a home run every single time.
Oh, thank you.
Yeah. And the reason I'm coming to you is I know that you're in the middle of your journey as a clinical medical student. And I'm curious, I'm always curious at what experience tells you then and at that stage. So have you seen anyone with palpitations? And if so, what lessons have you drawn from that?
I actually haven't seen anyone with palpitations. I actually have my medicine block next. So
nice.
I'll probably see a lot then.
Probably will.
Yeah. But in terms of my thoughts so far, I think it's really interesting that he doesn't really have any past medical history. I feel like if I were kind of going down the cardiac route, like any heart disease, doesn't seem like he has heart disease. You would kind of see a more chronic picture. But it seems like the palpitations are kind of maybe more acute onset. And I think it's really interesting that he's saying that he's hearing it in his ears, in his right ear. It makes me think that maybe there's some kind of like pulsatile tinnitus. Maybe it's due to like turbulent blood flow of some kind, or it could be like Meniere's, who knows. And the fact that it's with fatigue, maybe he has some kind of aortic stenosis. I don't know. Yeah, that's kind of my thoughts right now. I'm leaning less towards like a chronic heart kind of issue, and maybe, thinking towards something maybe more zebra than kind of chronic kind of, Those are my thoughts right now.
Jane, I set this situation up such that if you succeeded, then I succeed, because I said to you, I'm calling on you because I know you'll hit a home run, and you get to pat your back because you just did hit a home run. And then by default, I get to, because I took a leap of faith poking on you. And I think what you've done is you've saved us from a critical mistake, really. When we are solving the wrong problem, you'll never get the right answer. Even if you're solving the right problem, you may not get to the right answer because medicine is hard. But if you're solving the wrong problem, you definitely won't get the right answer. And that's the key question here. What's the problem? Is the problem palpitations, or is the problem pulsatile tinnitus? The truth is that there's no reason that it has to be or. There's no reason it has to be pulsatile tinnitus or palpitations. It could be pulsatile tinnitus and palpitations. Why? Both of them map onto a disorder of the cardiovascular system. So this patient could totally feel whatever this is in their chest and feel it in their ear. But I think what you just did there is you pulled out and emphasized a key piece of history, which changes the game in most patients with palpitations. Why? Most palpitations have nothing to do with the heart. I work in the emergency room in the VA, and we see a patient reporting palpitations maybe once a day or twice a day in the emergency room. And the vast majority of those patients report that sense of discomfort, have no evidence of an arrhythmia on prolonged monitoring. And that what that sensation may be is something as esoteric as fasciculations of their chest wall muscle, implying a disorder in Muhammad's wheelhouse, or a condition we never diagnose. Most palpitations are idiopathic and unknown. So you have to talk to the patient and say, in whom am I going to be worried about who has palpitations? And that's where, I forget, I'm going to pull up the chat to make sure I give credit where credit is due. I think it was actually Jorge who was saying, I need to know red flags, because most people with palpitations won't have red flags, but some people will. And pulsatile tinnitus is definitely a red flag. So now I'll ask the group a question in the chat. I would love for all of our energy to be directed at this question because it's an important one. How do we distinguish tinnitus from pulsatile tinnitus? How do you go about doing that? Because that's key, right? We want to be solving the right problem. How do we know this is not just regular old tinnitus? So I would love for your advice on that and get your thoughts in the chat. In the meantime, I'll ask Man another question about the practice of medicine in Saudi Arabia. Man, I'm curious, you said this patient doesn't have a past medical history. And I know in Lebanon, there's not much impetus or pressure or even culture to do primary preventative care. Nobody goes to the doctor unless they're really sick. So one reason that he has no past medical history is because he hasn't been to a doctor in 76 years. What is it in general? What is the culture in your area about people going to a doctor routinely without any illnesses?
Well, I think it's variable. It's not consistent among people in Saudi Arabia. Some people, they do actually go to a doctor, to a family physician in order to have a regular checkup. However, others, maybe they don't have access to healthcare, and with eligibility criteria and having to have, an health insurance in order to gain access to a doctor. So I think it's variable, especially for citizens and non-citizens. It depends also on the work that they are doing. If they are laborers or if they are doing, jobs that have good payback.
Mm-hmm. That's very, very helpful. Thank you. Mohammed, tell us more about what you're thinking in the chat.
I'm not sure, honestly. That's something that just came like, that's what I would improvise if I'm in the room and trying to to find out if it's pulsatile or not. The easiest thing I would ask, do you feel it like with your heartbeat, or can you correlate it? And if he can answer that, then it makes it easier. If he doesn't, then I can use a stethoscope, listen to the heart, and then ask him to like tap the table each time he hears a whooshing sound in his ear. And then if it correlates with the heartbeat, then it's pulsatile, I guess.
100%. That is a brilliant idea. I absolutely love it. Raheel, long time no see. You have another idea. Can you unmute and share it, please?
Well, it's just like, hello, guys.
Hello.
Good afternoon. Here is afternoon, just. I have the same opinion, like you'll put a stethoscope under the ear just to hear the whooshing of the blood vessels, if you hear anything. So it's just tinnitus palpitation or pulsatile tinnitus. If you didn't hear anything and the patient said that I hear tinnitus and something like that, it's pure tinnitus, not pulsatile tinnitus.
Absolutely superb. Brilliant, my friend. And can you remind folks where you're calling from? We haven't seen you in a while.
Yeah, it's been like 4 months. I have not joined the Zooms, and tonight I had just time and I joined it. I'm from Kurdistan, north of Iraq. Amazing. I'm from Erbil. Yeah, and I'm just practicing medicine now as a rotator in emergency hospitals. It's been like for 3 months. Amazing. And in future days, I'll present cases. So I have a lot of cases.
Amazing. I can't wait for it. It's so nice to hear your voice. I saw your join the Zoom. It made me very happy.
Thank you.
I see Jorge has, you should also look at Jorge just plugged the Curbsiders episode on palpitations, which is absolutely superb. I highly recommend that. And if anyone can grab a link to that episode, you should totally put it in the chat, but no worries if you're focused on this case. Let me share one piece of advice. When patients are worried, as they often are with palpitations, you want to hold that angst and that concern as much as possible. And whenever you're trying to figure out if it's pulsatile or not, if you are in the patient's face and in their space and like doing stuff to them, they may feel another kind of palpitations and it may be confusing. So what's my trick? My trick is I discreetly feel their pulse. Or maybe if they're right-handed, I will feel the pulse of their left hand. So I know when the pulse is coming. And I ask them to use their right hand to tap out when they feel the tinnitus. And if what I feel with their left hand corresponds to what they are tapping from their ear, I'm much more confident. Okay, so why do I suggest this approach? 2 reasons. 1, you want to be the control for the pulse, not the patient, because you don't have access to that data. If you have access to that data, you'll be much more confident of it. And 2, you want to minimize the distress to the patient by you putting something on them to cause even more palpitations. So be very subtle about it and just put your finger right over their pulse and ask them to tap it out. I think that meets the 2 goals of you making sure that you get the input of the pulse, and 2, being as subtle about it so as not to cause other forms of distress. Okay, so I think that Jane hit a home run here and is telling us what's the problem. Is it palpitations or pulsatile tinnitus? We'll talk about a differential diagnosis of pulsatile tinnitus if it comes up and if it really is the problem. So I'll hand Aman back the mic to give us more data.
All right. So just with regards to the palpitations. So he was describing it as this fast beating sound in his right ear. He was not very able to tap it on a table, but he was just annoyed with it. And that's why he came to the hospital. It was continuous for the most part, running for 5 to 10 minutes and then stopping for a few minutes, 1 to 2 minutes, and then it comes back. Not related to exertion and no clear provoking or relieving factors. So I'll just go through the constitutional or the review of systems quickly. Again, the patient did not have any fever, no change in appetite, no weight loss or night sweats. The patient did not have nausea or vomiting, no change in bowel motion, no change in urine. The patient was not feeling dizzy. He did not experience any syncopal attack, no headache, no change in vision or hearing. He was hearing okay. And it's just for this beating sound in his right ear. Again, the patient did not have any respiratory symptoms, including a cough, sputum production, or sore throat. He did not have any joint pain or bone pain, no skin changes, and no chest pain, no shortness of breath, and he was not feeling any palpitations when it comes to palpitations. And with regards to his past medical history, again, he is not known to have any past medical problems, but he stated that he does not visit. He did not have, a recent visit. He does not regularly visit a doctor. He's not on any medications, no previous hospitalizations or surgical procedures, and no history of blood transfusion. And he's also not known to have any allergies to food or drugs. I will combine the social as well as the family history together because I think they are related. So the patient is originally from Chad, which is a country just to the west of Sudan in Africa. And he came to Saudi Arabia a long time ago when he was young, maybe 40 to 50 years ago. He initially started to work in a Pepsi factory and his job involved stocking packages. He then went on to work with his employer on multiple types of jobs. And the most recent job, which he quit around 7 years ago, was taking care of his employer's small farm. That involved also sometimes taking care of the animals over there, such as camel and sheep. And he did report, that sometimes he would drink raw milk. So the patient comes from a small village in Chad. In terms of family history, he's not aware of any medical problems in his family, in his parents or other family members, simply because he comes from a small village and there is no doctor around. He last visited his village around 1 year ago. He was married, but his wife passed away 2 years ago, and he has 6 healthy children, all of whom are married, and he is currently living with his son. So that's it for the history.
Man, it's such an incredibly rich background history. I really admire how rich and this history is all the way back from where he was born to the work he does, to the exposure he has to his children. I think it's very, very thoughtful of you to collect all this data. Maria, you have some thoughts about camels. I think it's Maria.
Yeah, but I have no thoughts. Although, I have to also applaud Aman for the history. I always like to ask, everybody in the hospital and my students if they can tell me something non-medical related to the patient. And I'm always disappointed when they say "Oh no, I forgot to ask about his life story," because that's the most important part. And I just think you did a fantastic job. I don't know what is relevant here. I hope they're not the camels, just because I love camels. They're my favorite animal in the world. But, all animals carry tons of diseases, especially the unpasteurized milk. But I can't seem to, the Venn diagram of things, I can't seem to Venn diagram Pepsi factory and palpitations, camels and palpitations. So it's taking a nice history is always pleasant. It's my favorite part in the job. But then you have to sort of figure out what's noise and what just makes for a good story and what's actually relevant. And right now, nothing really speaks out to me in terms of, ooh, this must be the step 1 correlation between palpitations and XYZ factor.
Oh, I couldn't agree more. Shema has some thoughts on what infection C's focused on. Shema, do you want to share them?
Sure. Thinking about yesterday's VMR, talking about unpasteurized milk, and there are some bugs to think of like Brucella, Listeria, or Mycobacterium bovis. And I was thinking that maybe pathogens like Brucella don't play a major role in here, because if he had something like this, I would have expected any form of endocarditis together with joint pain. So I wouldn't stick my focus on the milk now.
Amazing. I couldn't agree more. Man, can I ask you, what is the teaching in Saudi Arabia in terms of the social and family history? Do you typically get this this rich history from all patients, or are you targeted in this assessment? How does that, how are you been taught to do this?
No, I just I try to make it, as quick as possible. But I like to, ask patients where they come from, especially when they are, from other countries. I'm interested to know where they come from, and especially like this guy who's 76 years old and he's not from Saudi.
Right.
So he had, a long history, an interesting, life journey. So I was just asking him, and yeah, that's it.
No, that's amazing. Can you give us a sense of what estimate you think, what % of patients you take care of that are not from Saudi Arabia originally?
A lot. Yeah. There are a lot of patients who are non-Saudi. Many of them, I would say, maybe half, 50% or even more. Wow. Yeah, because, as I mentioned earlier, our hospital, accepts everyone. Yeah. There is no eligibility criteria. So for most people in Riyadh, whenever you are in doubt, just go to Shemasi or KSMC and they will accept you.
That's so incredible. That's something to be very, very proud of. And so what language do you find yourself communicating in with people with all these different backgrounds?
So it's either, Arabic or English. Most of them, they understand Arabic. However, sometimes it's a bit challenging, but you can always, ask for some help from, nursing staff, since that, nursing staff, some of them are from, India, some of them from Indonesia, the Philippines. Right. So, there are always people who can help you. Yes.
Yeah. Absolutely. It's analogous to the situation here in the United States, where people are of so many different backgrounds that even though we all strive to use formal interpreter services, it's very hard to use. And so we often lean on our colleagues who speak different languages. Now, this is incredible. Thank you for this very rich history. Maybe I can give you the mic to give us the next aliquot.
Sure. All right. So for the physical examination, starting with the vital signs. So patient was vitally stable, a bit, apart from being a bit tachycardic. His heart rate was around 110. His respiratory rate was around 18. He was not in acute distress. And his blood pressure was 116/60. His temperature was 37 Celsius degrees, and therefore he's afebrile. And he was able to maintain adequate oxygen saturation on room air with a 96%. On general examination, so the patient was lying supine, comfortably on bed, was not in acute distress. He had irregular or normal body habitus. He was alert and oriented. On examination of his hands, he was noted to have pallor in the nails. His radial pulse was regular. It was fast with good volume. On examining his eyes, he was noted to have conjunctival pallor, but no scleral icterus. And on examination of his mouth, he had, good mouth hygiene. He was not dehydrated, and there were no signs of bleeding or any changes in his gums. On examining his neck, so he was not noted to have a raised JVP, and there were no cervical lymphadenopathy. On palpation, his trachea was midline. The thyroid gland was not enlarged. And then examining his chest, so he had bilateral air entry, vesicular sound without any adventitious sounds, no crepitations, no crackles. On examining his heart, a patient had the apical impulse was not displaced. He had a fast heartbeat, but apart from that, no murmurs or gallops were heard. And then examining his abdomen was soft and lax, no tenderness elicited on superficial or deep palpation. And he was, I could not appreciate any organomegaly, no hepatosplenomegaly was noted. When examining his lower limbs, he did not have lower limb edema, and he did not have any skin changes, no rashes or bruises were noted. So in examining his lymphatic system, he also did not have any enlarged lymph nodes. So all in all, his examination was unremarkable apart from the pallor and the conjunctival pallor. That's mainly it.
Incredible, my friend. Your presentation is so poised and polished. It's incredible. My friend Barbara has a question for you. Barbara, do you want to, if you're able to unmute and ask Man that question?
Can you hear me?
Yes, perfect.
Oh, great. My first time ever unmuting.
I know. I've been here for so long. Do you want to tell us about yourself?
I come from the PA world.
Amazing.
I live in North Carolina, somewhere in between AMK and, I'm blanking, in Charlotte's, ID guy. Anyway, so I'm very curious about this right ear situation. And since it's pretty easy to look in an ear, I seem to be wondering if perhaps there's a bug in there.
Yeah, totally.
Because I haven't heard that he's feeling these palpitations in his chest. But anyway, it's pretty easy. He has a right ear complaint, and let's look into it.
Barbara, it's so nice to hear your voice. I think you've been an ever-present member of the CP Solvers community for such a long time, and I, to be honest with you, jumped at the opportunity to have you unmute when you participated in the chat because I've been itching to get to know you better. And thank you for telling us about your PA background. I think we all lean very heavily on our PAs. I'm not sure if you've where you're at in that space, where you practice, but thank you for joining us and for asking that very practical and very important question. Man, so did you have? Yes, go ahead.
I did not have an otoscope, but just looking at the ear, there were no changes, first of all, on inspection. He did not have any discharge or skin changes around the ear. And he did not seem to have, any hearing problem. He was hearing me okay.
Great, gotcha.
So I would say it was unremarkable.
It's, it's amazing. In the emergency room, it's hard to find the tools available in primary care, like an otoscope. I completely agree with you. It's unfortunate, but often a reality. Thank you for sharing that. Shadi has an interesting observation about the intermittent nature of it. Shadi, do you want to unmute and tell us what you're thinking?
Yeah, of course. Hello, everyone. So the fact that I saw many speaking about the fact that he was in conjunctival pallor and he has signs of anemia, but what's very strange that it was not associated with exertion, and like the episodes was lasting around 10 minutes and resolving on its own. So like that shifted my thoughts about likely more like of an arrhythmia, since he is 76 years old. That increase in age is by itself a great risk factor. So that's what was my only thought about it.
I think it's, you're, again, just like Jane, you're helping us make sure we don't solve the wrong problem. And by saying, hey, anemia can cause pulsatile tinnitus, but it should cause it in a manner that is continuous, not so erratic. So the erratic nature of it should make us question that hypothesis. And I love that very simple line of reasoning. Thank you so much for sharing it. I will say, I just noticed how much I'm blabbing and how it's already 43 minutes into the hour. And so I will just share one piece of advice, which summarizes the wisdom on the chat. Conjunctival pallor is very specific for anemia, but does not leave content or does not comment on the nature of it. So you cannot jump to the conclusion this is iron deficiency anemia. All you can say is this is anemia. Anemia of any kind can cause conjunctival pallor. But I think Shadi's discrepancy here is really important. How can anemia be present with pulsatile tinnitus? Pulsatile tinnitus often implies a vascular disease process, be it intracranial hypertension, an arteriovenous malformation, or a local dissection. And the connection between a vascular process and bleeding, the connection between vascular process and anemia is bleeding. So could he be bleeding in his GI tract or somewhere else, and that same vascular lesion be located in the neck area? I think that's a hypothesis to entertain, but we'll see where the labs take us. So I'll pass the mic to you, Man, to give us the labs.
Sure. Okay, just a second, let me pull them. So I have the labs over here. All right, so his glucose was 6.9 millimoles per liter, which is elevated. His BUN was 20.4, which is also elevated. His creatinine was 94, but normal for his range. The sodium was 136, potassium was 4.6, AST was 15, ALT was 16, alkaline phosphatase was 51, LDH was 318, which is elevated. His total bilirubin and direct bilirubin were within normal limit. Unfortunately, we did not have the phosphate and calcium as well as magnesium in the initial labs. With regards to his CBC, so his hemoglobin was 4.8, his WBC was 17.7, which is elevated, and the platelet count was 10. Anything else that you would like to know more about?
Alrighty, while the chat gets their thoughts in, I'll just summarize. So he has is his white count neutrophils, Man, or is there a differential on the white count, or is
sure.
it?
So for the differentials, the patient differential. So the neutrophils were 6% of the total WBC count. The lymphocytes constituted 7%, and the monocytes were 86%.
Wow. He had 86% monocytes. That's a lot of monocytes. Okay. See how that changes everything? You know, the chat was silent, and then everybody's jumping in now. Yeah, and then and his sodium is high at 156. Is that right?
The sodium was normal, actually. It was 136. Sorry.
36. Okay, no problem at all. And then his glucose is elevated. His BUN is high, but his creatinine is normal, right?
Yeah.
Okay, perfect. Okay, Hans, what are your thoughts?
I had to find the unmute button. Yeah, when I heard high WBC and then the high monocytes and low platelets and low hemoglobin, I was thinking about a leukemia and probably something, involving the monocytes, and that could be AML or maybe a chronic myeloid leukemia, something like this. So we need further investigation.
Beautiful. And Anne-Marie coming in with the hyperviscosity thought. It's just so brilliant. Anne-Marie, do you want to share and unmute?
Yeah, I just worry about, I'd be very curious about the total protein levels, just thinking about hyperviscosity, especially if there is some sort of leukemia or like kind of depending on the type of cell. So I'd ask about like mucosal bleeding, other focal neurologic symptoms and stuff like that, just with the pulsatile tinnitus.
Absolutely superb. Y'all, how did we make it this far without me sharing a schema? It's like a weird Saturday today. The reason the chat was stunned was kind of like slow when we heard the white count and then jumped into action afterwards was because you all realized that this was very funky. What that means is that we all expected the neutrophil to be elevated, and that doesn't change anything. It's boring old inflammation. But this case, from my dear friend Man, kept the funkiness hidden to himself until we prompted him. And what does funky inflammation mean? It means that there's a specific signature in the case that changes the differential diagnosis. Lymphocytosis, mono. Eosinophilia, parasite. Monocytosis, cancer. Basophilia, cancer. The truth is the monocytosis here changes the calculus tremendously, but you have to be careful. Monocytes can be erroneously misread and not be monocytes because the automatic machine can misread them. They could be blasts and they could be lymphocytes. So I would send it for manual review to confirm they're monocytes. That's step one. Step two is the most common cause of severe monocytosis is something that Abdulaziz, Ravi, and others have mentioned, CMML. The caveat is that there are acute versions of this, and those would be acute myelomonocytic leukemia, or AMML. And the reason to worry about AMML here is the lack of lymphadenopathy. Most CMML will come with prominent lymphadenopathy. There is also a small but important differential diagnosis of non-malignant monocytosis that may take us back to the milk exposure, including brucella, which was already mentioned. But I think the key question is what Anne-Marie said. How do we link in? And what Barbara emphasized a long time ago. How do we link in this ear thing? And the most simplest explanation would be turbulent flow in the carotid and vertebral as a result of hyperviscosity, or another feature of the leukemias, which is extramedullary hematopoiesis. So could he have a vascular mass in that area as a result of extramedullary hematopoiesis? But I would say for the sake of time, maybe Man, you can tell us the rest of the case right until the answer came back so we can have one final chance at getting close to it.
Sure. So I will just mention another lab finding, a finding that is important in such case, and that's the coagulation profile. The coagulation profile for this patient was within normal limit, and fibrinogen level was also within normal limit. And as was mentioned earlier, when you see the monocytosis, it might reflect a neoplastic process. In other words, acute leukemia. And therefore, we have to confirm that. So one of the important things that you have to do when you are in the ER receiving such case is that you have to send an urgent peripheral blood smear in order to look at the morphology of the cells in peripheral blood smear. And that was sent, and the peripheral blood smear came back. It showed, just a second, trying to find. Yeah, so the peripheral blood smear reads severe anemia and thrombocytopenia, monoblasts / promonocytes, blasts equal 90%. And the comment is that patient is having acute leukemia. One of the important things also to look in the peripheral blood smear, since that we are considering an acute myelogenous leukemia,
Man, your voice is gone.
Can you hear me now?
Yes, that's better.
Sorry about that. Okay. So one of the important things to consider as well with regards to the peripheral blood smear as well as the coagulation profile is that since that patient is probably having an acute leukemia, it might be an acute promyelocytic leukemia. And those patients are at risk of developing disseminated intravascular coagulation or DIC. And therefore, it's important to keep that possibility in mind, because they might need to be treated right away and be sent to a critical care unit. So when it comes to acute leukemia, of course, after the morphological assessment using peripheral blood smear or a bone marrow aspirate, we have to look at the cytogenetics as well as the phenotype of the cells using a flow cytometer or immunohistochemical studies. And the immunophenotyping came back positive for CD117, CD33, CD13, and CD34, which are markers of acute myeloid leukemia. It was also negative for the markers of acute lymphoid leukemia, and those include the CD2, CD3, CD4, CD5, CD10, CD19, and CD20. And currently, the cytogenetic studies are still pending, but the patient was labeled as having an acute myeloid leukemia that is minimally differentiated, and that's AML M0. And he was started on chemotherapy.
I don't even know what to say. This is such an incredible presentation and put together in a way that was so intriguing. I'll just be honest. I think in this case, you easily could have just said, this is a simple case of leukemia, but the way you told us the story was very engaging, including keeping the differential to yourself until we thought about it, which was really, really a nice way to get all the crowd thinking. And a case that begins with palpitations that ends with leukemia is always one full of learning. The one question I have for you is that, was the pulsatile tinnitus just a red herring in this case, or how did you connect that to the final answer?
Well, I think that this fast beating sound in his right ear was just basically a palpitation.
I see.
Because eventually it went away. He was transfused, of course, with blood as well as platelets, and he was feeling fine and feeling much better.
Incredible.
And it was gone. He was really annoyed with with the sound.
Yeah, you're getting a lot of love and gratitude from the chat. I hope you have a chance to look at it. It really
so the ECG.
Yes.
Yeah, that's great. So the ECG showed normal sinus tachycardia, no ischemic changes, no Q waves. His chest X-ray was also normal. It did not show cardiomegaly. The costophrenic angles were clear. There were no infiltrative or opacities seen in the lung fields. It was normal.
Normal, absolutely amazing. Yeah, I think the presentation here is absolutely superb. What clinical reasoning pro can I share with you all? Don't ever get married to a clinical finding. You thought that was life advice about your personal life. You should do whatever you want. I don't care. That's the space of VMR. But don't ever get married to a clinical finding. If you got married to pulsatile tinnitus here, you'd be stuck. Everything is a working hypothesis until you get more data otherwise. And the one thing to consider developing a permanent diagnostic relationship with in this case is the monocytosis. But you learned, just to hammer that point home, that was also wrong. This patient didn't have monocytes. He had blasts. all those were blasts. So even the thing that led us to the answer because we had a mimic for that thing, right? We said, oh, monocytosis, like that's going to be the answer, but only because our schema for monocytosis has said, wait, before you call it monocytosis, review the smear and make sure it's not blasts, right? So even that, if you were married to that, it took us astray unless you were prepared for being astray. So in clinical reasoning, remember that even if you are convinced somebody has something, you always have to keep the door open. We were convinced he had pulsatile tinnitus, turns out he didn't. We were convinced he had monocytosis, turns out he didn't. But when you accumulate enough data, all these CD markers, blasts, you become convinced enough. And remember, don't get overly attached to anything in diagnostic medicine. You might always have to change. But there's much more to this case than just a diagnostic medicine. And I'll pass the mic to Maria to conduct her wisdom and reflect on the context of this case, especially with you from Saudi Arabia visiting us today.
Ooh, this was so much fun. I learned so much, especially from the start, how you set up. It really reminded us that, you know, it's all cases, right? But there's a person behind it. And I think you did a beautiful job. Just, you know, I could picture this gentleman at your hospital very well. And that is something very hard to do. And now we're going to go. I know we're running a little bit out of time, but I'd love to ask you a couple of questions. And if anybody in the chat has any questions for Man and Mohammed and our Saudi friends, you can put it in the chat and we'll try to plug it in. We always start with food. I'm a very food-oriented person. So maybe I can ask our friends who I met earlier, Omar and Anas, if I go to Saudi, what should I eat?
Shawarma, definitely.
You want to know the funny story? I'm going to send you a picture, but I live in Guatemala, like all across, like very far away from you. And I don't even live in the city anymore. I live in like a very small rural area, and it's like 2 hours away from the city. Like a lot of the population don't even speak Spanish. It's very rural, and there's like a shawarma spot there. And I'm like, why is there a shawarma spot here? And I have to go try it because I don't know, like it doesn't seem authentic at all, but maybe I'm surprised and maybe there's like a Saudi person running it. Could you imagine? I'll tell you when I go get it. If it's not shawarma, what else should I try?
Definitely traditional kebab places, rice and chicken, rice and meat.
Okay, that all sounds so good. Anas, do you have any favorites you'd also like to share?
I would say a dessert called arika, which is essentially crushed bread with dates and honey. And although it's like calorie dense, but I think it's worth it.
Ooh, that sounds so yummy. I know Mohammed also likes to cook. Do you have any like sweets favorite that we'd also need to try, Mohammed?
I mean, honestly, there's really good kunafa here, kunafa places. That's one thing I would definitely try.
That's like the cheesy stuff, right? Because that's like the vermicelli stuff. Can you describe it?
It does look like vermicelli, yeah.
I'm like Googling it, but it sounds so yummy. Thank you so much. I definitely would like to try all of it. I'm gonna go back to Man. I know that you have a very, you've been in your hospital for 5 months, and then, you know, dealing with so many different people and patients as the one that you presented today. How has it been? Like, how do you manage dealing with patients who have a different cultural background or like a different language than yours?
I think it's really interesting. Sorry about that. So yeah, I think it's really interesting having this, you know, kind of patient population that we are dealing with. And I'm really enjoying it because you're basically practicing medicine. Each patient that you see, you really don't know what they have. Sometimes, certain, group of people, they might have or be predisposed to certain conditions more than others. And sometimes you get, in touch with those patients. I remember one patient, he was like 1 day away from his flight back to his country, and he had a stroke. But thankfully, it was a minor stroke, and he was able to, get better very quickly. And other times, because of this exposure to people from different nationalities, you also get exposed to certain issues such as, access to healthcare, and who's eligible for treatment and who's not. And I think that our hospital is doing such a great job with that, because they have many agreements with charitable organizations. And so for the most part, any patient who comes in, if they are not eligible for treatment, you just, call the case manager, they're gonna take care of it. And the patient eventually, for the most part, would not, pay that much for their treatment. The challenge is mostly after discharge and the follow-ups. You wanna make sure that they are able to adhere to their medications. And that means that sometimes you have to, oftentimes I have to look up the expense of the treatment in order to, make sure that they are able to afford it and, continue taking their medications. And they also come, with different educational backgrounds. So sometimes it's challenging and interesting at the same time to try and explain what's happening to them, so that they understand what's going on and how they can take care of themselves.
Wow, thank you so much for that reflection and your stories. They're very powerful. Sometimes we sort of forget that we don't practice medicine in like a bubble, and we actually deal with things outside of medicine, and those are much more important than a lot of the medicine when it comes to management and diagnosis. And I think it's something that we don't talk enough, how like the challenges present themselves even after you've made the diagnosis, you made the treatment, but then like you lose the patient, as you said, and that's very challenging and sometimes frustrating. And thank you for sharing it. It's something that I'm also learning how to like process. And it's nice to hear that, you're not alone. A lot of people, a lot of people and physicians deal with those problems too. And Moha, I wanted to ask you, I was thinking about a question for you because I know we share a lot of interest. And, Mohammed loves words and languages much more than I do, and he knows much more than I do, but we always talk about, curiosities in the Arabic language and how Arabic and Spanish are sort of cousins in all sense, in a lot of senses. But do you have any, fun facts about the Arabic language that you'd like to share with us today?
Yeah, I have a really nice one. So a very nice state which Rabia is living in right now, California, actually comes from the Arabic word caliphate, or the caliph, who was the ruler of the Muslim empires, like after Prophet Muhammad. And the story goes like that there was this Spanish author whose his name is Don Quixote, I think. I'm not sure if I'm pronouncing it correctly. I'm sorry about that. But he had this story about an empire that was led by female warriors, and the ruler, her name was Khalifa, or something along those lines. And that empire was rich with minerals and like a lot of resources. And that's a very old story. I think the novel is like in the 1400s. So when the conquistadors found California and found that it's so rich, they called it, this is the empire that he talked about in the novel. So they called it California.
Wow, that's how you know Mohammed's gonna be an amazing neurologist. Like, who else, if not a neurologist, can tell you such a fabulous story on the spot? Like, on the spot. This was not prepared. He did not study it for sharing it. He just knows so many cool facts. That was awesome. Thank you. I had no idea. That was fascinating. And I'm just gonna put like another question. Mohammed, maybe you can ask some of anybody of your friends that I haven't called on. But what are the places that we would need to visit in Saudi if we ever went there?
Murshid, would you like to mention some of the places that we could visit in Saudi?
Yes, Murshid.
Maybe you can't hear us right now, or you can't talk right now. Let's see who else is here. Anas, anything?
I mean, Saudi, there's a lot of range of things you can do in Saudi Arabia, but my favorite places would be the southern part of Saudi Arabia. There's a lot of mountains. There's a lot of activities you can do there. Generally, people, when they think of Saudi, they think it's a very hot country, but if you go to the south part of Saudi Arabia, the temperature is really nice. It's rainy, a lot of mountains. So I would highly recommend the southern part of Saudi Arabia.
Ooh, that sounds so nice. I'm not a very like mountainous, adventurous person, but I'll go visit anything, anywhere. Shema has actually a really good question for you. Shema, do you wanna ask our friends?
Sure. My question was like, how is the system of med school in Saudi Arabia in terms of getting access? Like here in Germany, we have a low capacity for med school, because yeah, and that's why I was curious about that.
Sure, I can take that. So there are a couple of government schools and there are a couple of private schools. The school that we went to, our Alfaisal University, is a private school, and they basically have they have an open admission policy kind of thing, so they can accept a large number of students compared to government schools, and most of the people in the private schools as well have a varied background. So I'm originally from Egypt. I have a couple of friends from Egypt as well. We have a couple of friends from Syria, a couple of friends from Saudi. So it's a very diverse background in the medical schools, in the private ones at least. As for the government ones, I think maybe Man could speak to that more. But yeah, there's enough doctors to go around, I would say.
Thank you.
Yeah, so for the governmental med schools, they are mainly for Saudi graduates from high school. And in terms of the number of graduates, I think is increasing each year. However, there are no enough residency positions afterwards. It's becoming more and more competitive, especially for non-Saudis, of course. Yeah, but I think we had a unique experience at Alfaisal University because we have people from different parts of the world, and that's in my opinion that was the best thing about Alfaisal, having the opportunity to connect with people of different backgrounds. And I'm really grateful for my friends, and I thank those who joined us today. I appreciate your support.
That is so nice. Diversity and diverse teams are so important. Like, they make everything better, literally, like statistically. You can search it up and that, they're always better at whatever you're measuring. Jane, you have a really good question. Do you want to open your mic and ask our friends?
Sure. I was just wondering if you had any helpful or good advice that you received during your training. If you would like to share, that would be really helpful.
For me?
Yeah, any of you.
Okay. Well, I remember on the first day of residency, the program director met with us, and I really liked what he told us. So he basically said, you know, when it comes to knowledge, I don't care about your knowledge. What's most important is your attitude, because with time, you are going to gain the knowledge that is necessary for you. However, you know, your attitude is what really matters.
Wow, amazing. I really like that. And I think you know, words are good, but your actions really showed that through how you presented the case and everything. You know, it really shows how it's your attitude towards the patient, towards continuous learning, sharing the case with all of us, your generosity, coming and speaking out with us on a very nerve-wracking Saturday for you. So that speaks volumes. And I, you know, just to be mindful of everybody's time, I'm just gonna finish up with one question that I hope is like very short, because I hope you've never experienced it, but do you have like any good like camel stories? Like, have you ever, like, has the camel ever been important to a case, or just camels are sweet and innocent forever?
So I haven't taken care of a patient that was directly involved with camels, or like their case was directly, but that being said, the neurology residency program director here always reminded us, if something is not adding up in terms of symptoms or localization, then you have to test for brucella. It's always a culprit. It's like the new syphilis here.
Oh, wow, the new syphilis. And coming from a neurologist, we better listen. We better listen. Wow, that was amazing. I'm glad that camels are not as bad as, I don't know.
Should I spoil your impression, or should I just leave you believing that camels don't cause severe acute respiratory?
You can ruin the fun for me.
No, I'm not going to ruin the fun. I'm not going to ruin the fun. But you should.
No, go ahead. Show us the camel bad stuff.
There's no schema. There's no schema for camels, but camels were implicated in the outbreak of the Middle Eastern version of another coronavirus that was, I think, in the early 2000s. Yeah, Ravi's mentioning it, MERS, Middle Eastern Respiratory Syndrome. So camels are incredible. But by the way, let's just keep this in context. You know what the most infectious living being is? You guys know?
I'm guessing mosquito.
Very, you know, by prevalence, 100%. It's probably up there, but I think we have them beat. 100% human beings. Oh my gosh, we're way more. You hear about this pandemic that we're doing right now, spreading to each other? Yeah, so I think camels are amazing. Relative to us, everything's incredible. Yeah. Yes, I know, Maria, that you were that was near your final question. So since I've hogged the mic, I just wanted to thank everyone for joining us today. It's incredible to me what's happening right now, and we have people from all over the world in all sorts of languages hanging out and nerding out together about camels, food, and medicine. And it is an honor. It really is an honor to share this space with you. And I hope our Saudi friends feel more comfortable and welcome to join us on any day, not just on the day that we feature them. So an open invitation to you, your friends, to come learn with us and learn from each other and get to know each other better. And for me, I really just want to take a moment to thank Mohammed for being a member of the VMR community and for making this happen, and for the one and only Maria, who continues to take CP Solvers to new heights and new places all across the world. I'll leave the final word to you, Maria, but thank you, everybody. It was a delight to hang out with you all.
Yeah, I have nothing else to add. Thank you so much for coming. Good thing that I know very little Arabic, but I know one word that works well for this, and it's shukran. So shukran.
Have fun. Thank you, guys.
Thank you
Bye.
all very much. I really appreciate the opportunity. And it was really nice meeting you all. Thank you.
We appreciate you. Thank you for coming. Everybody have a nice weekend.